once I get the go live
Mhm.
feature figured out.
Yep.
Yeah. Okay.
What's up? We are on live streaming on Regenix Facebook, Regenix LinkedIn. We are on YouTube on both channels, and then my own personal Instagram. And I'm Dr. Torrance. This is Dr. Pappas. We are Sarasota, Tampa, St. Pete, and Orlando. And we are here to help answer any questions about interventional orthopedics. Dr. Pappas, I see you've been posting a lot of stuff on knee issues. Do you want to kind of dive in and kind of give me a little bit of breakdown on what knee issues you see respond well to what we do?
Yeah. So we treat a lot of different issues in the knee. We treat ligament tears, we treat meniscus tears, we treat osteoarthritis from mild all the way to advanced. Just for starters, we treat bone issues, joint issues, and soft tissue issues. So we also treat, patellar tendons, quadriceps tendons, etc. But this week I was posting a lot because a recent study came out. It was a 10-year follow-up to a study from the New England Journal of Medicine that took a look at how patients did after meniscus surgery for degenerative meniscus tear. And this study was very interesting because what they did was half the patients in the study got meniscus surgery and the other half actually were put to sleep, and a couple of holes were poked into their knees to make it seem like they'd had meniscus surgery, but they didn't actually have the meniscus operated on.
Mm-hmm.
And so when this originally came out a little over 10 years ago, it was pretty remarkable because the patients actually at 1 year follow-up at the time were approximately the same between the two groups. There was no additional benefit for the patients who underwent the meniscus surgery. So 10 years later, the findings are actually more important because what it shows is that the group that got the meniscus surgery is actually doing substantially worse than the group that didn't. And this is because that meniscus surgery removed some of this shock absorption ability from that patient's knee. Over time, the patient had developed more arthritis in the knees that were operated on compared with the knees that were not. And so long term, this is very important because a lot of patients undergo meniscus surgery when they get tears, and they end up with more advanced knee osteoarthritis than they would have had they not had the surgery to begin with.
Yeah. So quick rehash. So two things I want you to take from this statement that Dr. Pappas is talking about. Number one, the 1 year outcome data for this showed that PT was no better than meniscectomy, so cutting out the meniscus. That showed that unless you have clicking, locking, and popping, there was no benefit to having a surgery on your knee. So PT coupled with PRP or bone marrow in the cases that we have would do fantastic, do better than surgery at the 1 year mark. Now at the 10-year mark, what they're finding, this is the second thing I want you to take from this, is that they're getting more knee replacements if you have a degenerative meniscus tear and you're operating on that degenerative meniscus tear. So two huge takeaways from that, in my opinion, and I just wanted to kind of rehash it real quick. Dr. Pappas explained it extremely well. So yeah, so we do this all the time. Knees are some of my favorites to work with, Dr. Pappas. Tell them about some of the ACL procedures that we do. And I just found this study, I hadn't even seen it, talking about how there was 66% of patients who have ACL tears actually can get better and go back to the level of play without having anything done. Did you see that study? It was British Journal of Sports Medicine. I shared it with you recently.
Yeah, well, I think with that study, the way that I read it
Okay.
was that about 66% of the patients who didn't have anything done for an ACL tear were at the same level of function as the most of the patients who actually underwent an ACL reconstruction, right? So when you tear your ACL, that's the main stabilizer in the knee, and oftentimes you're told you need ACL reconstruction surgery, and that's definitely the case for a lot of patients. It's more the case if you have other injuries at the same time, if you have significant instability, and if you're young. If you're a young athlete in particular, I think it does make sense for a lot of those patients with large retracted ACL tears to get an ACL reconstruction. But when you look at the long-term data for a lot of patients, it may not make sense for them to get surgery because they're at the same level of function as those people who didn't get surgery.
Yeah. And on top of that, we have a procedure that we do with bone marrow concentrate for some of these tears, grade 1, grade 2, and grade 3 non-retracted, that have fantastic results for patients returning to the same level of play and having healing in that ACL. And I'm dropping the links to these studies here in some of the comment section on each of the sources that we're at. But if you want to read it yourself, you can check it out. But these are kind of, we're breaking it down for you. Double board certified physician here, board certified physician over there. These are the experts in the field. We're not the guys who are sitting there on Instagram just giving you some perspective that they have no credibility. They shouldn't be talking about it because they have no idea what the heck they're talking about. That frustrates me every day, Dr. Probus. I don't know about you.
Yeah, so a big important factor in being able to treat an ACL tear is being actually able to inject the ACL, right? And so a lot of people out there in the regenerative medicine space, they're just doing joint injections, a lot of times blind. Whereas in order to treat an ACL tear, you need to be able to guide a needle directly into the ACL, usually in multiple parts if it's fully torn, and then putting something like bone marrow concentrate in that ligament to give the best chance of healing. We do that typically under fluoroscopic or X-ray guidance. We put a little bit of dye in the ligament to make sure that it's flowing the way that we need it to, and then put the bone marrow concentrate into that area where it's torn in order to stimulate the progenitor ligament cells to put more ligament down, put more collagen down, and start stimulating the healing in that ACL ligament.
Yeah, and if you haven't gone to our website, Dr. Pappas has a fantastic blog that he wrote with 3 of his patients where you can see the images before and after the ACL injections. And it's fantastic. It looks much, much better on MRI follow-up, and the patient felt a lot better. Am I wrong in saying that, Dr. Pappas?
Yeah, it's great. So being able to heal full thickness ACL tears with these procedures is really rewarding. Somebody who's had an ACL reconstruction himself, because my tear unfortunately was totally retracted, so it was not going to get better with that kind of procedure. I can say it's really rewarding to help people be able to avoid that surgery. And so being able to do that with a minimally invasive procedure is wonderful. And so what we do is we get, obviously the patient has an MRI beforehand where they're diagnosed with the ACL tear. And then usually somewhere between 6 and 9 months afterwards, we get a follow-up MRI to check in on the healing after the procedure while they're rehabbing.
No, that brings up a fantastic point here, Dr. Pappas. You're someone, we're all these clinicians here, we're happy to give a second opinion for somebody that's been told they need surgery. If you have been told you need an ACL repair or reconstruction, please come see us for a consultation. Sometimes they're a partial tear that would be amenable to our procedures. If they're not, we're definitely going to tell you that where you can go and steer you in the right direction of surgeons and people that we trust. And that's really one of the biggest things I want anybody who comes to any of these discussions that you and I are having, me and Dr. Zakis, any of the colleagues here, we're going to give you an honest opinion. We're going to spend a lot of time with you. We're really going to dive in and do a thorough history, physical, clinical exam, and also a diagnostic ultrasound. And if we can't help, we will help steer you in the right direction. Our mission and goal is to get you back to doing everything you love through non-surgical image-guided injections. However, if we can't get you there with that type of procedure, we will definitely steer you in the right direction. I think that any of the people I work with, any of the physicians I work with, I trust any of them to do procedures on me. So,
excellent. All right, Dr. T. Well, we've got a patient on the table. Speaking of which,
well, listen, go do the great work. Again, if you want to schedule a consult, Dr. Pappas is in Tampa. Go see him for anything might be bothering you: knee, back, shoulder, hip, cervical. He does a fantastic job with his image-guided procedures. We have locations in Sarasota, Tampa, St. Pete, and Orlando. If you want to give us a call, 941-357-1773. That's our main number. You can request to be a new patient. We do have some links in here to go on the website. Dr. Pappas got to go see a patient. I do too. Thanks, guys, for the time. See you.